It's my pleasure to present this talk for the audience today. The title of the talk is More Coronavirus Myths and Misperceptions. And so, looking at the coronavirus pandemic for the years 2019 to 2020, we can kind of look at what has happened during the pandemic over the last several months, and particularly an examination of that also requires looking at online myths that can shed light on what the public is thinking about the pandemic at a given time, because accurate information is essential to ensuring public cooperation with health advice during the times that we're in. And misinformation, like the coronavirus, is a viral threat. It's for this reason that back in May, I held a previous presentation looking at coronavirus myths that were circulating at the time. So I thought I would do another talk looking at current coronavirus myths and misperceptions. Now, where can one investigate coronavirus myths? There are several online resources that are available. For one, national media outlets. Like many in the audience, I look at my favorite national media outlets that I think represent accurate information and check them daily. One that I like to talk about is MedPage Today for those who are medically inclined in the audience. They have an excellent summary of the current coronavirus stories that are out on a daily basis each morning. There are several fact-checking resources that I also consult: factcheck.org, Pointner.org, which is an affiliate of our local newspaper, the Tampa Bay Times, and then Snopes.com. Snopes.com is a sort of a fact-checking website that hosts information about all sorts of online myths, not just related to coronavirus. It's worth checking out. So with that in mind, we also need to talk about social media. And of course, social media can spread misinformation about COVID-19. Now, for those of you who want to check out my coronavirus myths recorded back in May, please refer to idpodcast.net. The link is located at the bottom of the slide. So with that information, let's get to our myths. Here are 10 myths or misperceptions or coronavirus-related statements that I think are worthy of further investigation. So number 10, N95 masks, surgical masks, and cloth masks can be dangerous and or ineffective at protecting against the spread of COVID-19. This was felt to follow a widely circulated Facebook post from June 2020. June was when a lot of information about mask wearing and a lot of local mask ordinances began to be reported across the USA. This individual suggested that based upon his OSHA training that masks were useless against the coronavirus. He claimed he was OSHA 10 and 30 certified, and he asserted several facts that several things he thought were relevant about not just N95 masks, but surgical masks and filter or cloth masks. He fed a narrative that wearing masks was not helpful to the COVID-19 outbreak. So we're going to look at each of his assertions on a separate slide. So the blogger said that N95 masks were designed for contaminated environments and were not for general use. And he said when you exhale through an N95 with a valve, that you're exhaling unfiltered air into the environment. So is this an issue? Let's take a look at it more closely. Well, N95s are really to be used in healthcare settings. And early on in the pandemic, N95 masks were in short supply. So hospitals attempted to obtain whatever N95s were available. Now, some N95s have what are called exhalation valves, and they're useful to prevent fogging of the mask and to allow the exhaled air to be properly vented so as to improve user comfort and, as I said, avoid fogging. But because N95s are meant to be used in the environments where the risk is really to the wearer rather than to the people in the environment, N95s utilizing valves were acceptable in the environments that they were used. And furthermore, most hospitals prefer N95 masks without an exhalation valve. Pappers and cappers, in fact, which we use at our facility, also ventilate unfiltered air into surrounding environment. But if you're in a room with a patient who has coronavirus or tuberculosis, the concern is more in protecting the user of the N95 rather than those in the environment, such as the patient. Now, N95s are considered standard of care for protecting healthcare workers from COVID-19, but they're not really meant to be used by the public in a normal outdoor setting. So this concern is not really valid for the use that N95s are currently intended. Now, how about surgical masks? The blogger said wearing a surgical mask makes you a walking virus dispenser. Surgical masks are meant for sterile environments. They clog easily and do not filter your breath. They acquire germs and then you breathe them again the next time you use them. So, these concerns are really overblown. Surgical masks are effective in reducing droplets exhaled by the user, so they protect others. But, recent data suggests that they also can reduce the exposure to droplets spread by individuals within 6 feet of the person wearing the mask. So they're effective not just in protecting others, but in also protecting the user. Now, of course, surgical masks are ineffective against airborne virus particles. This is the reason why N95 masks are used in healthcare worker environments. But surgical masks can be used for a prolonged period of time. They don't clog in non-sterile environments. And if you go to a CVS or a Walgreens pharmacy, you'll find them for sale to the public, and they're much more effective than other masks that are intended for use in casual environments when you're going out and about. Now, how about cloth masks? The blogger said cloth masks don't filter anything. They trap CO2 and make you sick. Moisture builds up, causes mildew, and then you breathe in fungus. Dry coughing, allergies, and sore throats are all due to moldy masks. So cloth masks are also effective against filtering respiratory droplets exhaled by the user, and they can also provide some protection for the wearer against other person's large respiratory droplets. The idea that CO2 levels build up when you're wearing a mask is preposterous. You can find many online videos and tests and also scientific evidence to suggest that this does not occur. Now, if there's any concern about cloth masks being a vector for mold or mildew, then the nice thing about these masks is, of course, they can be washed frequently to eliminate any risks. And the blogger's claim that his OSHA 10 and 30-hour training makes him an authority is really not valid. These certifications do not include information about COVID-19. So masks do help prevent the spread of coronavirus, and mask use, as we all know, is universally recommended by the CDC, WHO, 36 or more states, and more than 70 countries. And large corporations, in the setting of the lack of a national mandate to wear masks, are increasingly recommending mask requirements at their places of business. Examples include Disney, Starbucks, Walmart, Publix, Winn-Dixie, for example, and many others. And masks do protect the wearer, even cloth masks, but most importantly, they protect others. We all know this to be true. So this pronouncement is false. Now, some individuals ask, why must I wear a mask in public when the government also asks me to, for example, wear a seatbelt, put a helmet on when you're riding a motorcycle, stay under the speed limit, or to not smoke in certain areas. Now, the reason why the government asks you these things is all of these mandates save lives. If not your own, then certainly those are the ones around you. So wearing a mask in public is no different than wearing your seatbelt. It's going to protect you, and potentially it's going to protect others as well. Now, what I've seen more recently online is some individuals thinking that other things constitute a mask. This is a so-called sheer mask. Now, some others have talked about masks being an issue with individual freedom. President Trump has not always been an advocate of masks, but 2 days ago he tweeted this photo and discussed mask wearing as a patriotic act. So anything we can do to encourage mask wearing, I think, is a good thing, although he has not always supported it. So if these healthcare workers and those healthcare workers in the audience can do this to save a life, then any individual can wear a mask to go shopping. All right, let's move on. Number 9, did recent protests spread coronavirus? This is a question that many had. In May and June of 2020, the uprising that occurred after George Floyd's death on May 25th at the hands of Minneapolis police led to widespread protests and civil unrest. There were concerns that crowded demonstrations would lead to surges in coronavirus cases in those communities. And large protests occurred in Los Angeles, Chicago, Washington, D.C., New York City, and elsewhere. You can see memes online of this fashion. All this rioting, protest, and looting, and not one peep from the media about how this could also be spreading coronavirus. So did these protests spread coronavirus? Well, actually, there was a study, and a team of economists at the National Bureau of Economic Research examined coronavirus case trends after the protests. And they looked at 13 cities. And the researchers noted that for COVID-19 case patterns to suggest an association, cases would have to rise within 2 weeks, and in some cases as little as 5 days. Now, out of these 13 large communities that they studied, researchers found that only in one of the 13 cities did case increases fit this pattern. And that one city was Phoenix in Maricopa County, Arizona. Their case rise fit the pattern, but whether the protests actually caused increases was less clear, since the state's stay-at-home order was lifted 2 weeks before the protests. Now, actually, they found that there was some evidence that the general public avoiding the streets may have outweighed the lack of social distancing by protesters. Now, these protests were largely outside. Most, but not all, protesters wore masks, and most protesters were young and less likely to show symptoms related to COVID-19. And the protests occurred in the wake of the relaxation of shutdowns in many states. And although Houston had marked increases in cases where protests occurred, New York City and Washington, D.C. had no increases and had some of the largest protests. So their conclusions were widespread coronavirus outbreaks do not appear to have occurred. And although individual sporadic cases among participants are plausible, it's more difficult to calculate because of the age of the protesters and some confounding factors like relaxations of shutdowns. So I think we would rate this statement false. Widespread coronavirus outbreaks did not occur as a result of these protests. So social distancing is helpful in most cases, but unfortunately not when you're playing Where's Waldo. So moving on here to question number 8. Resistance to mask wearing during a pandemic is new. And just want to remind everybody to mute your mics, check and see if you have an open mic, and please mute your mic if you wouldn't mind. So early during the 2020 COVID-19 pandemic, public mask use messaging was mixed. And when many governments moved to make mask use mandatory, there was widespread resistance from many groups. Some saw it as an affront to their personal liberty. There were inconsistent mask recommendations early on, especially, and this may added to the development of controversy. And some saw it as a generational absence of personal responsibility. We here in 2020 are just not willing to pitch in to do our part, and this was really a sign of the times. But was the resistance to mask wearing during a pandemic new? Well, actually, in October of 1918, during the Spanish flu pandemic, the U.S. Public Health Service circulated leaflets recommending that all citizens wear a facial covering. And the Red Cross also took out newspaper ads. Several states out west, California, Utah, and Washington, launched their own initiatives. And with the U.S. entering World War I, messaging framed the mask guidance as a patriotic act and a civic duty. And numerous communities across the West instituted mandatory ordinances punishable by fines or jail sentences. This is a picture of several police officers wearing masks during the 1918 pandemic. And this is a collage of newspaper headlines related to 1918's influenza pandemic. You can see on the bottom left, open-faced sneezers to be arrested. Flu curfews were in effect. There were police raids in saloons to keep church window, and the advice was to keep church windows open. And non-essential crowds were barred, sounding very familiar to what we're experiencing today. And non-compliance and defiance soon became a problem in communities with mask ordinances. Many businesses refused to bar customers, and workers complained that masks were too uncomfortable. Things came to a head so much that in San Francisco, there were so many arrests that they began to run out of jail cells. And when the second wave returned in January of 1919, a second mask decree was instituted, and it led to the formation of an anti-mask league. And 2,000 protesters packed an ice rink to rally and protest, including, remarkably, physicians. So the statement, deeply entrenched ideals of individual freedom, inconsistent messaging, misinformation, and poor acceptance of sound scientific recommendations by businesses and many members of the public, sounds like 2020, but these were also recurrent themes during the influenza pandemic of 1918 to 1919. But sadly, 100 years later, little has changed. The Spanish flu ultimately killed 675,000 in the US, and COVID-19 has killed 141,000 so far in 2020. So unfortunately, the idea of resistance of mask wearing as being a 2020 phenomenon, this is false. So moving on here to myth number 7. Hospitals are inflating COVID-19 deaths and cases for financial reasons. The origin of this myth originated around April 8th after a Minnesota state senator and family physician, Scott Jensen, implied on a cable TV interview that the number of COVID-19 deaths could be inflated. He suggested that a motive might be that hospitals get higher payments to admit COVID-19 patients, and if a patient goes on a ventilator, they get 3 times the reimbursement. Now, this interview was picked up by social media and was widely circulated, and it led to the perception by many that hospitals were misreporting COVID-19 data. So this is a story as reported online, and his comments, Dr. Jensen is on the left, the interviewer is on the right. He said, anytime healthcare intersects with dollars, it gets awkward. Right now, Medicare has determined that if you have a COVID-19 admission to the hospital, you'll get paid $13,000. If that patient goes on a ventilator, you get $39,000. Nobody can tell me after 35 years in the world of medicine that sometimes those things impact on what we do. Well, this claim was actually reviewed by PolitiFact, and Medicare does pay more now for COVID-19 cases, about 20% more than its standard rate, but this is as a result of the CARES stimulus bill that was passed early on in the pandemic. And it's customary for hospitals to get paid roughly 3 times as much for a patient on a ventilator than a non-ventilated patient. This is not new. And evidence suggests, in fact, that COVID-19 cases are being undercounted, not overcounted. And this idea of the financial peril of U.S. hospitals was actually written about in a JAMA article in May. And the author remarked that because of limitations in hospital capability for allowing COVID-19 patients to be admitted and also non-COVID-19 patients, many hospitals are closing outpatient departments, postponing or canceling elective visits and procedures. And these are some of the more lucrative ways that hospitals make money. And this potentially threatens the financial viability of hospitals, especially those in smaller communities with pre-existing financial challenges, and also those heavily reliant on revenue from outpatient and elective services. So whereas some might allege that hospitals are actually benefiting from COVID-19, quite the opposite is true. And we can see that in our own institutions that are struggling under the weight of all of these COVID-19 patients in Florida, whereas not being able to conduct elective surgeries and outpatient procedures and so forth. And that extends to physicians and other healthcare workers as well, who have their own practices. And when interviewed by factcheck.org, the physician in this interview, Jensen, said he was misrepresented. PPE, additional equipment and infrastructure costs, extra staffing, and the idling of elective procedures have crippled the financial health of many hospital systems. And the future of healthcare, unfortunately, may involve many smaller hospitals and medical practices going out of business, leaving only the largest players who can weather the storm. And this is not what we want to see for our hospital systems or our healthcare networks or medical networks. So this idea that hospitals are inflating COVID-19 deaths and cases for financial reasons is simply false. Moving on here to question number 6. I wonder how many people in the audience have heard about so-called COVID parties. Do COVID parties exist? There have been recent media reports describing multiple episodes involving coronavirus victims, often young, who are said to have attended large gatherings where COVID-infected persons were intentionally invited to see, quote unquote, who could get it first. Well, these stories usually follow themes related to the pox parties of old, where parents got kids together with chickenpox infected children so that the kids could just be exposed and, quote unquote, just get it over with. This was actually the subject of a Simpsons episode from the past. And but then again, aren't Simpsons episodes the subject of everything? The show's been on for more than 25 years. Well, there was a New York Times article from July 12th recently that reported about a 30-year-old man from San Antonio, Texas, who had died. And he stated to the medical staff that he had deliberately attended a gathering with an infected person, quote unquote, to test whether the virus was real. And just before the man died, he told his nurse, "I think I made a mistake. I thought this was a hoax, but it's not." Now, the New York Times, unfortunately, could not independently verify the claim. Now, a second occurrence occurred right here in Florida and involved a teen and cancer survivor who had an autoimmune disorder and attended a large church gathering in early June. Now, the church called the event a quarantine release party, but an online coronavirus activist, Rebecca Jones, who came to notoriety after previously running the Florida Department of Health's coronavirus dashboard, in her Twitter account, she referred to it as a COVID party. Now, the teen, of course, unfortunately died 2 weeks after the event in a Miami-Dade hospital. The church, however, defended itself, vehemently denying that it was a COVID party, insisting that they had taken strict precautions. And Ms. Jones later revised her description of the event on her website and retracted the idea it was a COVID party. So do COVID parties really exist? Well, there's no question there has been much irresponsible behavior occurring in different localities. This was the Lake of the Ozarks during Memorial Day, for instance. And these activities have led to documented coronavirus cases. But gatherings simply organized to promote the spread of COVID-19, similar to pox parties, do not bear up to scrutiny when further investigated, though this does not definitely rule them out. There's simply more evidence needed to confirm. So people need to stay safe, and hopefully the message will get out to avoid the types of things that we saw in the Lake of the Ozarks and other areas. But the idea of COVID parties, I'm going to rate that a mixture, neither false nor true. I think we just need more information. But definitely these ideas of having COVID parties are not scientifically sound and do not bear out and are strongly discouraged. So moving on here to myth number 5. Will COVID-19 soon no longer be classified by the CDC as an epidemic? This was widely circulated in social media after being reported on the politically leaning website Just the News on July 14th. The headline read, "COVID-19 is close to losing its epidemic status in the U.S. according to the CDC." And it cited a CDC COVID View weekly report ending the week of July 4th. And it suggested that at the time, the declining deaths over the previous few weeks would statistically knock out COVID-19 from epidemic status as the deaths fell below the so-called epidemic threshold. And the article followed several reports on the alternative media supporting the notion that the coronavirus pandemic was less severe than the media was reporting. And this concept was subsequently amplified on places like Facebook. But the report was incorrect. The prevalence of the disease, not the number of deaths, is considered by the CDC to be its main indicator of its epidemic status. And the data cited by the article was incomplete. And we've seen this recurrently because oftentimes death certificates often lag behind other epidemiologic data. And this is one of the reasons why death reporting has been delayed as our coronavirus cases have increased. And we can see a little uptake in deaths here in the 7-day average line in this data reported as of July 15th. And in fact, since July 4th, reported deaths have indeed made a resurgence. And as of this lecture, the CDC has made no pronouncements about ending the epidemic status of COVID-19 in the US. And this would be preposterous as we are experiencing unprecedented deaths, and a continuing rising of cases in many states. So this is obviously a false assertion. Okay, moving on here. Number 4, were Obama, Fauci, and Melinda Gates at the Wuhan lab in 2015? In July 2020, a social media photo was circulating showing then U.S. President Obama, Anthony Fauci, and Gates Foundation co-founder Melinda Gates at the Wuhan Institute of Virology. Many of you may be aware of the Wuhan Institute of Virology. I discussed it further in my previous podcast. It is the Chinese version of the CDC and has been around now for 5 or 6 years, has done a lot of research in the bat coronaviruses because of their proximity to areas in China where coronaviruses are believed to be endemic, particularly in bats. And the Wuhan Institute of Virology, of course, was also the subject of some myths in social media and others as being the intentional scientific lab that released the coronavirus. So this social media post referred to a $3.7 million grant that the Obama administration funded to the Wuhan Institute of Virology for a quote-unquote bat project. And it suggested the involvement of the so-called deep state at work years before the coronavirus pandemic to somehow seed the origin of COVID-19 years later. Well, let's look at this social media post in more detail. This lab is not in Wuhan, but it's actually in Bethesda, Maryland, at the NIH's Vaccine Research Center. And the meeting that occurred in 2015 was about Ebola research. And the woman to Dr. Fauci's left is not Melinda Gates, but then U.S. Secretary of Health and Human Services, Sylvia Burwell. Now, a $3.7 million grant was awarded, but it was not to the Wuhan Institute of Virology. It was actually to the New York-based Echo Health Alliance, which studies the epidemiology of diseases. Now, the Echo Health Alliance did award $600,000 of that money to the Wuhan Institute of Virology, specifically to help study bat coronaviruses, where there was not a lot of research about how these coronaviruses leave the bat vector and present a risk to humans. And although this $600,000 was criticized by the Trump administration earlier this spring and ultimately canceled in April, it was actually renewed under the same administration in 2019. So the idea that there was a deep state at work and Obama and Fauci were involved in the Wuhan Institute of Virology, obviously this is false. And it's consistent messaging like this that can spread doubts about coronavirus and lead the public to believe that coronavirus's origins were not from nature, but were an intentional act. And in my previous podcast, I talk about some of the myths involving the Gates Foundation, for example, and I would encourage everyone to listen to that as well. Okay, we're in the home stretch here. We have 3 more to go. Number 3, are 99% of coronavirus cases harmless? In a 4th of July speech, President Trump made several comments about the coronavirus pandemic. He said, "We have tested over 40 million people. By so doing, we show cases, 99% of which are totally harmless. Results that no other country will show because no other country has testing that we have, not in terms of the numbers or in terms of the quality." And he faced backlash because many public health experts knew that his comments were not accurate. In fact, the president's press secretary claimed that the president was referring to the case fatality rate. So the case fatality rate, in this case, is calculated by dividing the total number of U.S. deaths, for example, 139,661 as of July 18th, by the total number of US cases. And by this measure, the case fatality rate is about 3.8%. But of course, many experts feel that the total number of cases, the denominator there, is completely undercounted. So the case fatality ratio may actually be closer to 1%. So if the true case fatality ratio is 1%, does that mean that the other 99% of cases are harmless? Well, of course not. 99% survival does not equal 99% harmlessness. And in fact, in June, the CDC published data on 1.3 million cases in the US from January 22nd to May 30th. And they found that out of these 1.3 million cases, about 14%, that's a tremendous number, were hospitalized. 2% ended up in the ICU, and about 5% of these patients died. About 13.8% of coronavirus cases, according to the WHO, have been labeled severe, and 6% have been critical. And not just talking about the acute cases, but the long-term effects of coronavirus infection are still being understood and can often be quite debilitating. In fact, there's a term now used called long haulers. And these are patients with coronavirus symptoms that extend not beyond their recovery, but many months off into the future, experiencing symptoms like chronic extreme fatigue, headaches, brain fog, shortness of breath, and some individuals even have chronic lung damage. So the idea of 99% of coronavirus cases being harmless is completely false. And in fact, the scientific community needs to do a lot more and will do a lot more over the next several years in understanding the long-term effects of coronavirus infection. Okay, moving on to number 2, the next to last of our myths. Does the US have the best testing? Now, the White House has repeatedly claimed that the US leads in the volume of coronavirus testing, and that aggressive testing has led to the US having inflated coronavirus statistics compared with other countries. And this has led many to question, how many tests have been conducted, and is testing responsible for the large number of coronavirus cases that have been reported? So let's look at the total number of COVID-19 tests as of July 18th. When you look at this measure, the United States does lead all other countries in the total number of COVID-19 tests. We've tested about 44 million persons as of July 17th, compared with Russia at almost 25 million, and then India and other countries in which coronavirus has occurred. But the total number of tests is just one measure. When you look at the rate of total COVID-19 testing, the tests per 1,000 people, the US is actually not the leader. There are 4 other countries, including Denmark, Russia, and Israel, that outpace us in terms of testing. And we're actually much closer to the pack of many other countries, not that far away from New Zealand, for example, or Canada. So in terms of COVID-19 tests per 1,000 people, we are nowhere near in the lead. And the Washington Post took a look at this in an article in late June. And they acknowledge that testing doesn't explain the rise of COVID-19 cases in the US. And when you look at coronavirus cases versus tests in the month of June, and this is from ProPublica on the left, in some of the states where coronavirus cases are surging, the amount of increase in testing nowhere near came close to the increase in cases. And in our state of Florida, testing actually decreased at the same time. Positive cases were increasing by more than 300%. So testing capacity has expanded nationally from under 20,000 tests a day back in March. That doesn't seem like it's that far ago, but it seems like a world away in our coronavirus pandemic, to more than 400,000 tests as of July 20th. But testing capacity has had to increase due to the sheer volume of new cases. And test positivity, an indication of how widely our testing penetrates into the community, has increased in hotspots like Florida, in certain communities like South Florida, to greater than 30% test positivity. And if more coronavirus cases were simply due to more testing, the percent positive should stay low. If we look at our own state, percent positivity for new cases has outpaced 10% for several weeks now. And the World Health Organization, in fact, recommends that countries that want to relax social distancing must have sufficient testing to keep our test positivity rate to less than 5%. And here in Florida and many other communities and states across the country, we are nowhere near this WHO indicator. And this suggests that we are, in fact, under-testing in our communities. We need much more testing than we have now in order to understand exactly how much of the community is exposed. So U.S. testing, though much improved compared with March, still lags behind other countries on a per capita basis. And current testing capacity is being outstripped by the sheer number of cases, resulting in long lines, delayed appointments, and waits of as long as 7 to 10 days, even 3 weeks in some cases. And when test results come back in 3 weeks, it's really useless. It doesn't allow us to quarantine patients, and it doesn't allow patients to understand whether they have coronavirus and to take protective measures. And widespread new sampling methods such as saliva, breath, or point-of-care antigen testing may hold the key to meeting our needs for more widespread testing. So this is false. All right, well, thank you all for staying with me here. We're down to our last coronavirus assertion, and it's about vaccines. Will there be a vaccine for coronavirus by early 2021? So many health experts see a vaccine as the only way out of a protracted and much more deadly coronavirus pandemic. And early data now suggests that coronavirus immunity from exposure may not be long-lasting and cannot be relied upon to produce indefinite immunity. But most vaccines take several years, as many as 4 years or more, to be developed and to be manufactured and released to the public. So with these types of experiences in the previous development of vaccines, is a coronavirus vaccine likely by the first part of 2021? Well, you can obtain information on the current status of COVID vaccine development on the New York Times website, where they hold a coronavirus tracker section. And according to the New York Times this week, there are 135 vaccines not yet in human trials, 18 vaccines in phase 1, 12 in phase 2, 4 vaccines in phase 3, and actually one vaccine, a Chinese vaccine, also approved for limited use. Yes, for those of you who are not aware, there actually is a vaccine approved for limited use for coronavirus. We'll talk more about it in a minute. So to understand how vaccines are approved and the process to get a vaccine to market, it's important to understand the status or the steps necessary for vaccines to be released to the public. So it all starts out with preclinical testing, where scientists give the vaccine to animals to see if it produces an immune response. If that is confirmed, vaccine testing goes on to phase 1 safety trials. The scientists give the vaccine to a small number of people to test safety and dosage, as well as to confirm that it stimulates the immune system. Once this is established, phase 2 expanded trials are held. In this case, the scientists give the vaccine to hundreds of people split into groups, such as children and the elderly, to see if the vaccine has any different characteristics in those specific groups. These trials further test the vaccine's safety and ability to stimulate the immune system. This past June, the FDA said that for a coronavirus vaccine to be released, it would have to protect at least 50% of vaccinated people. This is a determination that it is effective. Now, once phase 2 trials are held, and sometimes phase 1 and phase 2 trials have been combined in certain coronavirus vaccines. So once these hurdles are met, phase 3 efficacy trials are held. And in this case, scientists give the vaccine not just to hundreds, but to thousands of people. And they wait to see how many become infected compared with volunteers who receive a placebo. And these trials can determine if a vaccine protects against a coronavirus. And once phase 3 trials are released, the FDA looks at the data and determines whether approval is warranted. And when approval is warranted, regulators like the FDA review the trial results, decide whether the vaccine is effective, and then approve the vaccine or not. And sometimes during a pandemic, a vaccine may get expedited or emergency use authorization before getting formal approval. So let's take a look at what are seen as the 3 most likely candidates for a vaccine to be released by early next year. The first is the Moderna vaccine. And this vaccine uses a new technique, messenger RNA, to produce viral proteins. So whereas traditional vaccines use, for example, a virus vector to carry proteins to induce the immune system to produce immunity, the Moderna vaccine actually uses messenger RNA, injecting that into a host so that the host can produce the viral proteins by themselves directly. The Moderna vaccine involves 2 vaccinations 28 days apart, and promising phase 1 results were published just earlier this month. The Moderna vaccine was found to have provoked neutralizing antibodies and appeared safe in 45 recipients, and phase 3 trials are set to begin on July 27th. And availability is thought to be as early 2021. So the next vaccine candidate is the Pfizer BioNTech Fosun Pharma vaccine. This vaccine is also a messenger RNA vaccine, just like the Moderna vaccine. And a phase 1, phase 2 trial data set was published in July. It also involves 2 doses, 21 days apart. And all 45 subjects in the trial developed neutralizing antibodies and beneficial T cells. This vaccine was given in 3 different dosages, and some vaccine recipients achieved some minor side effects, mainly sleep intolerance, some insomnia, and sore arms. But it was generally well tolerated. And the FDA granted this vaccine fast track status on July 13th, meaning that this will help with manufacture of the vaccine before perhaps approval is granted. And up to 100 million doses of the Pfizer vaccine are promised by the end of the year. Now, the third vaccine candidate is the AstraZeneca Oxford University vaccine. And this is a viral vector vaccine. So this is a traditional vaccine utilizing an attenuated virus. It's based on a chimpanzee adenovirus called ChAdOx1. And results were recently reported for a phase 1, phase 2 trial in the Lancet. And this trial involved a much larger set of volunteers, about more than 1,000 volunteers. And in the trial, the recipients developed good antibody responses, and the vaccine was well tolerated. Now, the AstraZeneca vaccine is now undergoing phase 2 and phase 3 trials, and an emergency vaccine supply is promised as early as October, and up to 2 billion doses are eventually promised of this vaccine. Now, what about the vaccine that's already approved? This was a viral vector vaccine, like the Oxford vaccine, by a Chinese company called CanSino, and it's based upon the AD5 adenovirus. And phase 2 results were reported just recently in the Lancet on July 20th. Now, the investigators claim that the vaccine produced a strong immune response. And as a result, the Chinese military approved the vaccine on June 25th as a quote-unquote specially needed drug. But the Chinese are unclear about a plan for vaccine administration, and there's no indication that this vaccine, as of yet, will be available outside of China, or even to wider groups than the Chinese military. So this vaccine has limited approval on an emergent basis, but again, not expected to be available on a wide basis. So the idea, will there be a vaccine by early 2021? Well, in my opinion, vaccine availability in the first quarter of 2021 seems likely. And we've seen very positive pronouncements from national experts like Dr. Anthony Fauci that a vaccine will be available by early next year. And the development of these vaccines has been aided by prior research that has already been ongoing in the last decade. And since the original SARS outbreak occurred at the beginning of the 2000s. Also, there's a unanimity of scientific interest. There are many, many scientists across the world working on this problem. And when you get many scientists together, breakthroughs can certainly occur on an accelerated basis. Many people see this as a horse race between the Moderna and Oxford vaccines. And there was an opportunity for volunteers to sign up to participate in the clinical trials of 4 of the leading vaccine candidates. And although 120,000 were originally requested, more than 138,000 volunteers are already signed up. And if there's anybody in the audience who would like to participate, you can reach out on the internet to see if signing up is still available. But keep in mind, of course, that you may be in a study that involves a vaccine versus a placebo, and you may be in the placebo arm, so you may not get the vaccine. But many people see this as a altruistic act to participate in further medical science. So it's always an option for the public to participate. There's one other footnote about vaccine development, which is the development of vaccine is also being aided by our sheer case numbers that we're having now. In order to participate in a clinical trial, especially an advanced clinical trial, it helps if you have active cases in the community, so that vaccine recipients or trial recipients can have a chance to potentially be exposed. This is much preferable to what are called live virus vaccine trials, where candidates are given the vaccine and then they're exposed intentionally to the coronavirus. Many ethicists see live vaccine virus trials as definitely being something we should avoid, because we don't yet know all of the potential adverse effects of coronavirus exposure. And it's much better to have natural occurring coronavirus cases, if they're occurring, as a way to test a coronavirus vaccine in a trial. So I rate this as the one and only true in our 10 statements for today. And I think it's definitely a good thing and something to be encouraged about. But maybe it's not a question about when, but how. And I would put forward these questions about when a vaccine becomes available. Who will be the first groups to receive it? Will it be the most vulnerable, or will it be healthcare workers, for instance? Will initial immunity be brief with a vaccine? Dr. Fauci was asked this question recently, and he said any vaccine, and even partial protection, is better than no vaccine at all. So he would encourage, even if an initial vaccine isn't the strongest vaccine, for it to be widely available. How many doses will be required? Obviously, a single dose producing long-lasting immunity is the best outcome, but this may not be initially possible. Will a skeptical portion of the adult public elect to decline the vaccine? Some national polls have suggested that even if a vaccine is available, about 50% of the U.S. public will not elect to receive it. And will the U.S. or other countries share the vaccine with other nations? This is important because this is not just an epidemic in the U.S., it's a pandemic across the globe. And we will need vulnerable communities and underserved nations across the world to be immunized as well to stop a global pandemic. And how long will it take to develop herd immunity worldwide? These are all important questions. So I want to thank everybody for participating today. Watch out for social media. This is a hotspot for coronavirus misinformation. Make sure when you talk to patients about COVID-19 that your messaging is consistent and clear, and make sure that they understand what we're going through. We can all play a role in delivering accurate and sensible information to our patients. And with that, I'll stop and take any questions.